Hi, my name's Conor Delaney. I'd like to welcome everybody to another episode of MD Insight, and I'm really delighted today to be joined by Dr. Mark Taylor. Mark is an anesthesiologist and he's our Chair of Surgical Operations for the Cleveland Clinic Enterprise throughout Ohio. And Mark, thank you for making time in this busy time as we reactivate during and after the pandemic to join me today and give us some insight. Maybe you kick off by telling viewers a little bit about yourself and your role, because it's something they may not realize the size and scale and magnitude of what you're involved in.
Well, thank you, Conor. It's a pleasure to be here today and to be able to share some time together as we reactivate and recover from what has been a monumental event across all industries, but most notably in our world in healthcare. As you mentioned, I'm a cardiac anesthesiologist and intensivist by training. I've been part of the Cleveland Clinic now for slightly over 3.5 years and have been afforded an opportunity to serve in a role that has been really exciting for me. I'm currently the chair of Enterprise Surgical Operations, and I really look at my role in surgical operations as to be the one responsible to ensure a smooth and efficient operating room operation. Anything that goes into the operating room, including supplies, equipment, staff, surgeons, anesthesiologists, have some connection to surgical operations. And we need to make sure that those behind the scenes features are up and running as smoothly as possible so that our patients have good access, our teams are running at an efficient metric, and that there's no challenges to get the work done, irregardless of date or time.
Well, I can only, as a practicing surgeon and obviously running digestive disease and surgery, I can only thank you for all your efforts, because the amount of patients that we're capable of caring for and the teamwork and that your team bring us is really fantastic, and I would argue probably unique, and it certainly allows us what we do to the level that we do it. So thank you for that.
Oh, you're welcome.
So obviously that all changed in mid-March and we went from having these highly efficient, incredibly busy rooms to scaling back because of the virus and the fears of how quickly it would infect patients and people and caregivers across the enterprise. And so we had to wind down very carefully and in a very considered way, and obviously we put a lot of effort into that. But maybe you'd talk through some of the concepts that were involved there and considerations and how we managed to do it for the enterprise.
Yeah, so I think one of the strengths of the Cleveland Clinic is obviously we're an extremely large organization in both Ohio and Florida. Speaking specifically about Ohio, we have a variety of care platforms that range from ASCs that take care of outpatient surgical therapy all the way up through strong regional hospitals that meet a community needs. And then we have some larger, what we term a hub hospital, that have a stronger medical staff with diversified services, including comprehensive stroke and trauma care and cardiovascular care. And then, of course, we have the main campus. When we were facing the pandemic and the unclear perspective as to the number of patients we would be treating, from mainly a medical perspective, I think one of our biggest concerns was how are we going to meet the needs of the patients outside of the operating room. We worked in close conjunction with the Ohio Hospital Association and the Ohio Department of Health to get a perspective as to what was coming from a surge of potential COVID patients. And as everybody knows, most states at various times in March issued an action to suspend non-essential surgery. Once we knew that non-essential surgery was going to be suspended in Ohio, that afforded us the opportunity to really look at what our platform was to provide surgical care at those 4 different structured locations. At our ASCs, we completely suspended operations and actually closed those facilities temporarily. That afforded us to move staff as well as equipment around the Ohio region to meet the potential surge that was coming. The other thing that we did clearly early was in our hospitals that had less than 8 operating rooms with a smaller surgical footprint every day, we went down to a 1 team per day concept. We still continued to provide surgical access for urgent and emergent surgical therapy. We also afforded some scheduling of essential cases by those surgeons, but this also allowed us to decrease our footprint dramatically and afford perioperative nurses, anesthesiologists, nurse anesthetists, anesthesia assistants, as well as surgeons, the ability to shift their focus to potential pandemic preparedness. And then at our hub hospitals and our main campus, we continued to run a footprint to meet the essential surgical platform that included a tiered concept within the institutes and the surgical service lines to meet the needs of our surgical patients that were still coming forward between the end of March and the 1st of May, when the Ohio Department of Health action was modified.
Right. And I think it was very effective. It allowed us safely scale back what we were doing and maintain, as you put it, essential services at all hospitals for emergency cases and do the important cases that, because of critical symptoms or other things, needed to be done. And then allowed us get extra anesthesiologists to ICUs and extra surgeons to ICUs sometimes, and people filling in the different roles that we did throughout the organization. But even in the care that we continued to provide, obviously one of the things we had to modify and put a lot of effort into was coming up with appropriate PPE provisions for providers. And then fears, even though we're pretty well stocked, that if there was a really massive surge, that we may be under pressure for particular types of PPE. So when you figure that across the organization and across all the operating rooms, which are very high volume PPE users, of stock, what were some of the things that were going through your mind?
Well, I think most people recall the images we saw the third weekend in March coming out of New York City, where they were hit with an overwhelming surge of patients and I think what was an unfortunate inadequate PPE supplies. I think what we learned over the course of the pandemic is PPE preparedness and PPE management is really locally governed. There is a lot of challenges in that space based upon supply chain and access to products. But what we experienced in Ohio is different than what teams experienced in either Michigan or New Jersey or New York City. I think what we did is we quickly came together as a team of experts from clinical areas, including surgery, anesthesia, quality, with our supply chain partners, and came up with guidelines so that we could be good stewards of our resources, be reflective of what we believed would be coming in through our supply chain areas, and also meet the expectation of our patients and our caregivers in regards to safety. We also had a very nimble team. We made several significant shifts over the course of the pandemic as we learned more and more about our community prevalence, as we learned more and more about how caregivers and patients were presenting with symptoms of COVID and whether or not there was a community-acquired or a hospital-acquired exposure issue, which we did not see. And decisions were made, and then within 10, 20, 30 days, we would change those decisions when other priorities became more apparent. One of the most significant things we were afforded the ability to do is we quickly stood up an N95 reprocessing center. We realized that N95 masks, especially the small ones, were going to be in short supply. We were concerned about our consumption rate, and a disposable product was going into the landfill. And so we worked aggressively in less than 2 weeks to build an offsite reprocessing center solely dedicated to the reprocessing of N95 masks using an FDA-approved platform of vaporized hydrogen peroxide. That allowed us to recycle the product and store it for potential future use. We continue to do that work today. I'm proud to say that we've not had to issue a reprocessed N95 mask to a caregiver, but every day that goes forward where we are able to collect mask that's been used in a caregiver area and then get it into our disinfection cycle and then get it back on a supply shelf is a mask that may be called into action at some later time as we continue to go through this evolving pandemic.
Yeah, and as of today, at the end of May, we're seeing slight increases. So hopefully the secondary surge isn't too bad, and hopefully we don't have to dip into those resources. But I think it was a really important and early step because we didn't know how bad things were going to be. So I think you and your team accomplished incredible things in setting it up to manufacturing FDA standards, so we know it's safe and it's a reservoir that we have. And then I think you brought up another really important point, which is the effort we put into as an organization coming up with the right algorithms for who should be using certain types of PPE in certain roles, whether it's an aerosolizing procedure or a non-aerosolizing procedure, anesthesia versus surgeons, intubation, and these are all really important considerations. And we might talk a little bit about the psychological consequences of that for people, but it brings up another concept, which is some of the even higher risk situations. And I know, again, you and your team put a lot of work, Mark, into the PAPR discussion and how we manage PAPRs around tracheostomy, because there was a little bit of evidence from SARS that people wearing N95s doing tracheostomies may actually be able to get coronavirus. So what are your thoughts on that, or advice for organizations moving forward and how they manage those?
Yeah. Well, I think PAPRs are an interesting product. They're a product that are only really purchased and utilized during epidemics or pandemics. So most healthcare organizations have bought PAPRs 3 times in the last 20, 25 years. We had a supply of PAPRs that were located in a variety of different areas, never fully managed by one central location or authority. So we've done a lot of work to ensure a good access to PAPRs for teams that need them. Our occupational health, in conjunction with quality and the clinical institutes, have agreed that N95 is the standard, but for caregivers that have a fit test failure, they should be afforded a PAPR, and we still maintain that. As you mentioned, though, the science and the reports that were coming out early in the pandemic suggested that for certain procedures, a PAPR may be superior, and we wanted to make sure that our caregivers were safe. So we partnered with surgical leads to look at certain surgical procedures, most notably laparoscopy or open tracheal procedures, as well as just standard intubations and extubations in a variety of locations, and really had a strong discussion as to how would we manage an N95 for all, how would we manage an N95 fit test failure, and did we have the resources to afford PAPRs for either tracheostomy teams or for endoscopists or for anesthesiologists doing their work. Again, in that flexible model, we came up with reasonable standards. We still afford N95s for intubations and extubations for patients that are of unknown COVID status. We want to make sure our caregivers are safe, and much of our endoscopy work is still being done with N95s. We have afforded, on occasion, in the ICUs, PAPRs that weren't being utilized at the time for some teams that were doing tracheostomies, but that's not been our standard approach for all tracheostomies. And we think that as we emerge from this pandemic and we get better testing, both of our inpatients as well as our outpatients, we'll have more rational use of both N95 and PAPRs by either a fit test platform or by a procedural-based platform.
Yeah, I think it's an important part of the menu of options we have to keep people safe when they're providing care. And to help manage people's stress, because it's certainly been a stressful time for a lot of physicians and other caregivers, whether it's around respiratory therapy or around doing endoscopy. I know our GI team, obviously, were very concerned because of the aerosolizing risk with endoscopy. It's good to know that as time has gone on, the data coming out suggests that while you might be able to detect the viral RNA in stool, for example, that it doesn't appear to be infectious. But we didn't know that, and it's still evolving, and these are still case reports and series, and we're building the evidence. I think it's also great, some of the evidence we're developing and putting together around safety for caregivers, because again, you mentioned it briefly, but just in case people didn't catch it, we're not seeing a signal of caregivers picking up COVID at work. And I think the algorithms that we've put together appear to be structured, safe, and gradually people are getting the confidence. But moving forward then, what do you think the future will be for testing around surgical procedures. Obviously, we're doing it for all surgical procedures at the moment. It's a little bit site dependent. Endoscopy, maybe you want to comment on that, but even short of right now, where do you think we're going to be in 6 months or a year with that, Mark?
Yeah, I think it's a great question. One of our core tenets of our reactivation strategy was to make sure that it was safe for our patients, safe for our caregivers. And testing is critical in that area. We all are looking at the literature to determine what is the risk of operating on a COVID positive patient, either unknown or unknown. What is the risk to the caregiver and occupational exposure? And we've been fortunate in Ohio and specifically at the Cleveland Clinic that we have enough testing capability to test our surgical patients. As testing becomes more and more available, we'd like to expand our testing platform to include more procedural patients. And I think in the next 6 months or a year, we will have across the board enough testing capability and a strong enough platform to know prior to admission or prior to a visit for a procedure as to whether or not a patient is COVID positive or COVID negative. Our one challenge has been, do you trust the test? The other challenge has been, do you trust the timing of the test? And I think as we go along and learn through this pandemic, the concept of self-isolation and quarantine, if you will, after you've been tested 2 to 3 days prior to surgery, is that enough to ensure that the team feels comfortable and that the patient's best interest is being served, that they haven't exposed themselves to a family member or a neighbor who may have had COVID symptoms. And we're watching that closely day by day. We've tested over 8,000 patients for preoperative procedures. And what we have found is that 44 of those 8,000 patients are positive. So our incidence in the community is extremely low. And many of these patients, when you ask them about symptoms, they do report the fact that they did have symptoms within the preceding 4 weeks. They just had never sought health care. And therefore, the first visit is our preoperative assessment. And the first test that they've been offered to rule out COVID is the preoperative COVID test. So our community incidence is low, and our platform seems strong to support low exposure risk to our caregivers, but more importantly, low procedural risk to our patients.
Yeah, I think it's worked very well. You're right. And it's allowed us remove that concern for patients that in the perioperative period, they might get a chest infection and we'd be worried they get a COVID pneumonia or something and be at high risk of a really comorbid, complicated recovery from surgery. And I think the other point you raised, which is important, and obviously it's going to be a little bit variable depending on geography and city you're in, but yeah, we're at about 0.5% positive, and many of those are probably RNA positive who are not infective anymore, and they're recovering from asymptomatic or minimal disease, which is good to know for our caregivers that it's pretty safe. Mark, in the last couple of minutes, maybe you'd tell us a little bit about reopening. We talked at the start about how we wind down and it freed up staff to go other places. Reopening isn't as easy as it sounds. It's not just we open the doors and we turn the lights on and everybody's there and supplies are there and people are there. So what are the things that you've learned about reopening that might be good assistance for others as they go through the same process at their organizations?
Yeah, I think reopening has been much more of a challenge than the urgent suspension of services or the urgent constriction that we went through the third week of March. I think our most important challenges have been related to environmental mitigation, the concepts of social distancing in our waiting areas for our patients and their families, our environmental mitigation in our areas such as our pre and post areas, staff lounges or lunchrooms, locker rooms have been a challenge as well. Because again, to ensure good social distancing as our teams come back to work is critically important. We also kept a close eye on our supply lines. What we have found is that many healthcare organizations are dependent upon one or two major distributors of items from paper products, scalpels, light handle covers, all the way up through expensive implants. And we wanted to make sure that as we reactivated and we recovered, we didn't see challenges in any type of supply line. Because if a patient doesn't have access to an OR because of either an implant's not present or we don't have a disposable light cover, both of those things are a non-starter for the resumption of surgical services. So strong relationships with supply chain, the development of dashboards and daily huddles to ensure that what supply chain is seeing arrive on their loading areas and distribution centers that then gets sent to our procedural and surgical areas is extremely important. I think the other thing is that it's bringing both patients and caregivers. Our patients are afraid to come back. They've watched a lot of news reports that have shown that healthcare went through a significant transformation. And so these are the early adopters to the new normal, and they're willing to come back because they need our care. But we have to be respectful that it has changed dramatically the way they engage healthcare and the way they engage our facilities. And then for many of our caregivers that were in surgical services, they were dismissed from their work on the end of March. They did some redeployment work. For many of them, this is the first time that they're actually coming back to work and caring for patients clinically as well. So I think it's a new normal of bringing people along. For many of us that have been working throughout the pandemic in clinical areas, the management of the new normal of having COVID and non-COVID patients together in hospital or OR settings feels comfortable. But we do have to be respectful that there have been some surgeons, some anesthesiologists, some perioperative nurses that haven't been working as much clinically in the last 60 days. So when they come back to work at the ASC for the first time in 60 days, it looks and feels different, and they're at a different point in their own personal recovery as to how to manage this new normal within healthcare.
Yeah, you bring up a lot of really critical points, and it's a whole lot more complicated than one might expect when you start into this journey. So the term new normal is true, but it's a very different normal to what we had. I'll pull out one point just in case there are patients watching this, which is that all of the evidence that we've been able to put together is that it's safe, and it's safe to have care. And increasingly we're seeing data about 38% drop in myocardial infarction or presentation with cancer or stroke or other conditions, often around 40%. And we know those conditions aren't changing in incidence or frequency. And it's often just that through fear or sometimes social or economic issues, patients are delaying care. So a reminder that it's safe, and if you need care, it's a safe place to get back to, hospitals that are carefully putting effort into this. So Mark, I'd just like to thank you so much. Offer any final comments. Looks like you had one there maybe perhaps, but really appreciate you taking time to chat with me today.
No, it's been a pleasure to talk with you today, Connor, and to obviously work with you over the last several years, but most importantly through the pandemic. I do want to share your sentiments that leadership at the Cleveland Clinic and throughout our organization don't want to have an unsafe platform for care. And so we look at that daily, hourly to ensure that we're managing the situation as it unfolds. But patient safety is our number one priority. Caregiver safety ranks up there as well. And we're managing this together, and we're going to reactivate in a phased fashion to ensure that safety is the highest priority.
Well, thank you, Mark. Thank you for joining me for this episode of MD Insight. And to those of you watching, I look forward to seeing you again at another episode.